Good evening, everyone. It's so great to see so many of you joining us. I invite you to say hello in the chat and let us know that you're here. We welcome you all and thank you so much for joining us. My name is Dina Zuckerberg and I am the Director of Family Programs at MyFace. I'm pleased to welcome you to our webinar. This program is designed to inform and educate individuals with craniofacial differences along with their families and caregivers. We also welcome all the healthcare providers who have joined us for this webinar, but please note that continuing education credit is not available for tonight's program. MyFace is dedicated to supporting the life journey of individuals with facial differences and their families by offering access to multidisciplinary care, education, comprehensive resources, and community. We offer virtual support groups for individuals with facial differences and their parents. We distribute newborn care kits especially designed for babies born with a cleft. And we provide housing for families traveling to New York City for care. We strive to educate patients, families, and healthcare providers through programs like this, the Transforming Lives webinar series. We raise public awareness about craniofacial differences and choosing kindness through our Wonder Project school assemblies and through our monthly podcast, My Face, My Story, where individuals can share their stories, be seen, and be heard. At MyFace, we believe that the world is stronger when every person, no matter how they look, is valued, respected, included, and empowered to achieve their greatest potential. And now, to tell us more about today's program, I'd like to introduce my colleague and our moderator, Pat Shabara.
Hi, everyone. Thanks so much for joining us. Really excited about this program. I just wanted to let you know what our learning objectives are. They are to define craniofacial microsomia, to explore the diagnosis and treatment options, to describe the care project for patients with craniofacial microsomia, and to discuss family psychosocial support options. We are joined by two wonderful presenters and one of our own MyFace families. Our presenters are Dr. Carrie Heike, who is Associate Professor in the Department of Pediatrics at the University of Washington School of Medicine, and co-principal investigator of the CARE study and a pediatrician at Seattle Children's Hospital. And although he's having some technical issues right now, we hope he will join us soon. We know he's coming. Dr. Craig Bergfeld, who is professor, Department of Surgery in the Division of Plastic Surgery at the University of Washington School of Medicine and Craniofacial Surgery Fellowship Director at Seattle Children's Hospital. We will also hear from our MyFace family, including Jazara and her mom, Michelle. After the presentations, we will open the program for participant questions. As you think of questions for the speakers, please enter them into the chat on your screen throughout the program. Please note we are not able to address individual diagnostic and treatment-related questions during this program, which may be better addressed with your personal healthcare provider. It is now my pleasure to turn the presentation over to Drs. Heike and Bergfeld.
Thank you so much. And Craig, do we have audio?
I don't know, do we?
We do. That's great.
Hallelujah.
Well, thank you all. We are very excited to be here today. And as you just heard, I'm a pediatrician with the Seattle Children's Craniofacial team. Dr. Craig Bergfeld is a plastic and reconstructive surgeon, also with the craniofacial team at Seattle Children's. And we are here today to talk to you a little bit about the care considerations for kids and individuals with craniofacial microsomia. So we're going to start by talking a little bit about the term. And this is a question that we get a lot, and I think it's really important to think about what's the benefit of a term? How do we think about the clinical diagnosis of craniofacial microsomia? And so I like this illustration from Dr. Grab from 1965 that shows some of the features associated with craniofacial microsomia. And if we think of the word craniofacial, talking about the head and face. Micro is small, and somia is part of the body. And so it's a very broad term that's descriptive. And the features that are typically involved most commonly include the ear, and the term for that is microtia. Micro meaning small, and otia meaning ear. And the lower jaw, which is the mandible, and the technical term for that is mandibular hypoplasia, or underdevelopment of the lower jaw. And typically this is asymmetric. And I think it's important to recognize there are no specific diagnostic criteria that everyone is in agreement about for who fits the criteria for this clinical diagnosis. And there have been a lot of people over time that have tried to get more specific nomenclature terminology. People have made a number of different recommendations. Some feel that the combination of underdevelopment of the lower jaw or asymmetric hypoplasia of the mandible, in addition to preauricular tags or extra tissue in front of the ear, or microtia, underdevelopment of the ear, with or without preauricular tags, would be considered within the spectrum of CFM. So what's important is to make sure that if we are using clinical diagnostic terms, the purpose of that is to make sure that we're taking the best care possible of our patients. And so the benefit really is to make sure that we're following the protocols that we know will help optimize care, and we're not missing things that are unique to kids with other conditions that maybe overlap. And so it's important to distinguish between craniofacial microsomia, for example, and a diagnosis of Treacher-Collins, which would have a different pathway. So when we use this term, we're being very inclusive, including all of these other terms. We're not saying the right term, but in order to facilitate dialogue and conversation and care planning, these are the terms that are included. And we also include what some people consider to be microtia or isolated microtia. And I also like this cartoon by Dr. Cohen that talks about kind of historically in medicine, we have an easier time sharing each other's toothbrush than each other's nomenclature. And so hopefully as we learn more and we deepen our understanding, we'll be able to get more specific. So how do we think about clinical care for children? And I'm a pediatrician, so I talk about children, but all individuals with craniofacial microsomia. And although considered a relatively rare condition, it's the third most common condition that we think about on craniofacial teams. The prevalence really ranges quite wide depending on how people characterize the diagnosis. So that can range anywhere from 1 in 3,000 newborns to 1 in 26,000. We don't know the cause for most kids who have the clinical diagnosis of craniofacial microsomia. And again, there have been tremendous number of studies over the past several decades and ongoing work. And I think what we've learned is that it's considered a complex multifactorial condition. Our treatment goals are very similar to all treatment goals for anyone who has a craniofacial difference, and that's really to minimize the impact of the clinical features and to optimize function. Our standard of care includes longitudinal assessments. There's lots of conversation about multiple treatment options. And when we talk about treatment options, we also talk about not doing any intervention. And then all of us on the call today are obviously big proponents of coordinated team care. And so I would like to nod to American Cleft Palate and Craniofacial Association. So I wanted to say that this is a caveat of a very general timeline of care. I think that we developed this years ago to try to make sure that we were thinking about the kinds of things that were important to consider at different stages of growth and development for kids. And so this is not specific. It definitely needs to be tailored for individual, but it gives us a general framework for how to think about different care considerations at different time points. And so we'll walk through today some of those time points, and I'll talk a little bit first about the pediatric perspective, and then Craig will talk about the potential surgeries. So for infancy, from a pediatric perspective, I think making the clinical diagnosis is really important. And this is because, as we had talked about earlier, you want to make sure that we're following the right treatment protocol, that we're thinking about the right evaluations and interventions that are appropriate. And so making that clinical diagnosis is important. And if there's any question, I have a very low threshold for requesting a genetics consultation and further discussion with the craniofacial team. I've also just listed out the things that are particularly important to identify, especially in newborns. Any challenges with breathing difficulties, any challenges with feeding, nutrition, and growth, and of course, hearing. And there was also a really nice webinar specifically about hearing, and I would highly recommend that people check that out because that is an area that has been evolving rapidly, and there are great pearls in that talk about the ways in which we think about hearing in newborns. So Dr. Bergfeld.
Thank you. So as Carrie was mentioning, in the early stages of life, we really focus on making sure that the babies are breathing well and eating well. And sometimes they require surgical interventions to help them breathe better or eat better. And sometimes that can mean something as life-changing as getting a tracheostomy, which can provide a baby with a good, stable, and safe airway and allow them to therefore thrive. We do try to avoid that if at all possible, and there are some times where we will do a procedure to make the jaw longer and bigger to help with breathing, although that is a bit controversial as far as how well that works in this group of people compared to how well it works in other groups of people. Sometimes kids need feeding tubes placed. This is also an age in early life where if a child is born with a small eye socket, like the picture in the CT scan there, that we may put in orbital expanders to help the orbit grow so that it will eventually accept an implant. And this is also a time where if babies have little branchial remnants or if they have a cleft of their corner of their mouth called macrostomia, that we would consider repairing these during this early phase of life.
So again, like most craniofacial related care, we like to do iterative assessments as kids grow and develop and change, and that's one of the beautiful things about childhood. So again, as kids age into toddlerhood, reaffirming that this is the correct clinical diagnosis. Again, we're going through the same general review of systems, and this is in complement to what kids are receiving through their medical homes, their primary care providers. We're paying particular attention to development and have a really low threshold for seeking early intervention assessment and services for those that demonstrate any delays. And again, I cannot emphasize the importance of oral health. We know that kids with craniofacial differences often will need orthodontic and later potentially jaw surgery. And so starting early with oral health is critically important.
Yeah, and again, this is a time where we hopefully have secured a stable airway and the child is now thriving, where we can start to think of other surgical interventions that they may benefit from, such as eyelid procedures if the patient has a coloboma, as shown in the picture on the top, and that would need treatment. This might be a time frame where we would consider treating that to make sure their vision develops normally. Also a time where we might consider putting in tympanostomy tubes to make sure that their hearing is adequate so they can develop speech as they hear other people speak. Of course, if kids do need airway interventions, they're beginning to show obstructive sleep symptoms, we always consider that would still be an option on the table during this time frame.
Yes, and so preschool, this is a really great age to start to ensure that kids are integrated into the discussions around their care and engaging them in why they're at the craniofacial team visit, kind of what are the things that we're going to talk about today. We're really interested in making sure that all kids are healthy and starting to learn a little bit more about the language that they're using to describe their overall health and how they're doing. So again, same considerations, and again, tailoring this depending on the unique needs of the child.
Yeah, and the other consideration is kids in this preschool age range, they're about to head off to school, and so they're going to enter a new environment with a bunch of kids their own age who they may appear different to or a new face for them. And so we again consider this is a time where if you elect to have an external ear reconstruction done with a porous polyethylene construct or what's known as a MedPort ear, this is a time frame where that might be done to to have an ear made before kids go to school. This is also a time where I start to consider whether, if patients have facial nerve palsies, whether they would benefit from a facial reanimation procedure to help provide movement to their face as they head off to school. And of course, as I said in the previous 2 slides, we're always considering airway. So as we ask our patients if their parents, if they snore at night, and if they are, then sometimes kids need to have their tonsils out to help them breathe better so they can get a good night's sleep before they go to school. I think did you go? Yeah, there you go.
I did. Yeah, so same again, kind of general considerations, growth, development, making sure that the transition to school is smooth and that children are set with any accommodations that they need, particularly around hearing. Kids are so dynamic, so always reassessing kind of current sleep patterns, any signs of snoring or obstructive symptoms, and being holistic in the way that we think about overall physical and psychosocial health.
Yeah, and this is an age range where a couple of other surgical procedures might be considered. This is a time where the molars are beginning to come in, and so if a child has a very small mandible and they aren't able to have a good occlusion where their teeth are coming together well, we might, this is an age range now where we could do a costochondral graft to create the ramus, or the ramus of the mandible and the temporomandibular joint, to consider helping their mandible grow. This is a time where if you're electing to have a autologous external ear reconstruction, some of the techniques promote doing this at around age 6 to 8, such as the Burt-Brent technique, that might be combined with an oral atresia repair if the patient is a candidate for that. And then this is an age where the orbits are beginning to stop their growth. So if patients have any orbital asymmetry, then we could consider doing orbital surgery to try to level them out.
You'll see a pattern here. So again, continued conversations as kids grow, develop, reevaluating any procedures that they have had in the past, kind of their thoughts and experiences around those procedures, and checking in as they're entering kind of the middle portion of childhood. And again, critically important to involve them in the conversations and the decision-making around care.
So as we get into that late elementary school age, another kind of external ear reconstruction technique becomes available, and that's the Nagata technique. This technique requires more cartilage than the Burt-Brent technique, and so we generally like to wait until kids are around age 10 for this procedure, as shown in the picture. This is also an age where kids are in mixed dentition. It means that they have both adult teeth and still have some of their primary teeth. At some centers, this is a time where they consider making the jaw bigger and longer by doing a mandibular distraction osteogenesis, or distraction. This is also a time, I think, where if they have some soft tissue asymmetries, you can begin doing fat grafting, knowing that patients may need a few sessions of fat grafting to correct the soft tissue asymmetry, or additional bone grafting to the mandible if needed. And of course, again, we're always asking about sleep and snoring, and trying to make sure our kids are getting good night's sleep and they're not having sleep apnea. Is this me still?
This is, I mean, I can try, but I think it'd be better.
So the reason I said some centers this do mandibular distraction osteogenesis in the mixed dentition. Some centers do and some centers don't. And there's a balance between the pros and cons of each. The pro argument of doing this surgery is that it has the potential to improve psychosocial aspects of facial asymmetry while kids are in school. And of course, the hope is that it will also potentially improve their airway. But it doesn't definitively correct the asymmetry. There's additional asymmetry surgeries that are needed. And these kids still often need orthognathic surgery when they're skeletally mature. And so you have to weigh whether, doing additional surgeries in the hope of improving the facial asymmetry is worth putting a patient through these multiple surgeries, or whether it's better to wait until they're skeletally mature and just do their jaw surgery then. It's a balance that every team kind of strikes, and we have to have this discussion with our patients, because each patient is different too. And then finally, this is basically the other argument, is that the orthognathic movements may be greater if you wait until skeletal maturity. They may require bone grafting. They may not be as stable as they would be if you had done distraction earlier. So that's kind of the argument for not waiting.
So moving on to the teenage years. So again, we're always wanting to empower kids and their families and engage really in shared decision making. And there's a lot of it, I would say, for individuals with craniofacial microsomia in particular. And we're wanting to foster independence. And a huge part of this is psychosocial health. And so making sure that we're discussing treatment options with teens and their parents, and also the ability to be really flexible, because hopefully kids are actively engaged in a lot of activities, and sometimes the idea of having a surgery might appeal, but not at this time. We've got to make sure that they're paying attention to all the things that are important in their lives. And for most of these procedures that we're talking about, they're not time sensitive. And so just making sure people have the information available, but also the flexibility to consider them at a time that makes sense for them. Again, reevaluating school, making sure that the transition to high school is going smoothly, that kids are getting the support that they need in school, and that we're helping them think about kind of where their craniofacial related care fits into all of the other things that they're doing in their lives.
Yeah, and so this teenage years are, again, kids are getting busier with school and with sports. We always have to keep in mind what our surgical interventions are going to do to interrupt their school, their sports, their activities. But this is also a time where if a patient decides they don't want a external ear reconstruction, but they would prefer an ear prosthesis, that might be a time where that would be made for them. This is an age range where if a patient has trouble breathing through their nose, or they have some nasal asymmetry that they want corrected, that we'd consider doing a rhinoplasty. And that's often in conjunction with additional fat grafting if they do need that. And then they are, in this age range, they're beginning to spend a lot of time with the orthodontist, either getting dental extractions from the team dentist or getting orthodontic manipulations made in preparation for that definitive orthognathic surgery when they are skeletally mature.
And then transition to adult. So again, this is not a process that happens at one time point. It's hopefully gradually over time. By the time kids are kind of late teens, early adulthood, the hope is that they're incredibly independent. They're able to advocate for the kind of care that they want. They have good access to the information from the assessments that have been done, any procedures that have been done, and why. Checking in. This is such a critical thing for all children, but particularly with our teens and young adults now, to check in on psychosocial health. And because we are part of craniofacial teams, I think we have unique ability to have those touch points to make sure that we're paying attention to the specific needs of the kids that we're seeing. Again, checking in about school, thinking about what's happening after school, making sure that any needs that kids have been addressed. And then we like to facilitate a genetics or genetic counseling visit at this time. And a lot of times it's because we haven't really talked about that since the beginning. And fortunately, there are lots of advances, particularly in genetic and genetic testing. And hopefully by the time kids are getting to this point, we'll have more information for them. And so to be able to sit down with a geneticist, genetic counselor, and talk about what we know, what we don't know, what testing options are available, I think is really also important. And it also helps us make sure that we're eliminating any misconceptions. So oftentimes I've heard teens talk about kind of what they think causes might be, and what they think their likelihood of having a child with a similar condition might be, and they're not at all kind of based on the data that we have. So that's a critical part when we're thinking about, as kids are growing up and starting to think about having their own families, making sure they have all of the information that they would want.
Yeah, and as they transition into adulthood, it's a time where surgically we really want to finish up anything that we may need to have done. So this is the time where that definitive orthognathic surgery would be done once they're done growing. Showing in the picture a virtual surgical plan for a two-jaw surgery, and then they need to finish off after the orthognathic procedure with additional orthodontics often. But then just really what little touch-up procedures, often they maybe just need a little additional fat graft here or there, or if they've had a facial reanimation procedure, a little Botox here or there to help with the symmetry of their facial movement, just so that we kind of get everything wrapped up, because I know how hard it is as adults to get comprehensive craniofacial team care once they leave the children's hospital setting.
So as Pat mentioned, we were going to make a little plug for research, clinical research. So Dr. Bergwald and I and many others are very passionate about making sure that we're also contributing to improving healthcare. We have a good sense of the current standards, but we're always looking to improve treatment options for kids and facilitate better healthcare delivery, better shared decision making, and generating knowledge. And so we've been fortunate to be part of several research projects that have been funded by the National Institute of Craniofacial and Dental Research. And this just gives you a sense of, over time, some of the questions that have come from families, from parents, from individuals about growth and development in the toddler years, understanding a little bit more about etiology. And our latest project, we're just wrapping up end of 5 years, trying to have a better understanding of the psychosocial and healthcare needs and unmet needs of individuals and families. And through all of this work, we've been fortunate to partner with a huge international consortium of individuals who are also dedicated to this. Advocates, there's no way we could do this without the motivation and participation of all individuals with craniofacial microsomia and their families. And so we highly encourage people to think about finding opportunities to participate in research. We also want to know the questions that are most pressing to the community so we can really advance care in this space. And so, yeah, a quick summary of that general information. So I think, again, it's important to understand why we're using this particular term. It's not the right term or the correct term, but it is the term that has allowed us for much more conversation in the craniofacial community about the current standards of care and how to improve care. That there's a wide range in the ways in which each child might be the clinical features that children might have. And that's important to recognize because two people with the same diagnosis might have very different needs and treatment plans. And that's why individualized care is so important. And then also, I think fundamental is, whenever possible, we highly recommend coordinated craniofacial team care. There are a lot of really fantastic ACPA approved teams, and we continue to work with people nationally and internationally to try to ensure that we're all following standards of care.
Awesome, awesome, awesome. So I wanted to now introduce our MyFace family, and I have had the honor of knowing and caring for this patient since she was about 4 months old. This is Jazara, who was born with craniofacial microsomia, and she, as you'll meet her in a minute, she is one of the most articulate 16-year-olds I think any of us have ever met in our lives. She's amazing, and her mom, Michelle, who herself is a clinical social worker. But just to give you a small background, and it's interesting listening to this conversation and the explanation by Carrie and Craig, because before she was probably 5 or 6, she had about 4 of the surgeries that that Dr. Bergfeld mentioned. She had mandibular distraction as an infant because of her breathing issues and significant jaw asymmetry, which also which attributed to her feeding problems. She has had a macrostomia correction, that side of the mouth. She has had removal of skin tags, and she's had tonsils removed, and so and these were all done before the age of 6. And so and I think it really does point out the real difference in the range of this condition, and that every child's journey is different. So I would really love if I could have Jazara and Michelle join me. Hi, ladies. Thanks for.
Hello. Hi, Pat.
So I am just so honored to have you. And I wonder, Jazara, I wanted to ask you first. I have so many different things I'd love to ask you, but in listening to that, to Dr. Bergfeld and Dr. Heike's a description of the condition that you have, what were your first thoughts? Because I was wondering what you'd be thinking when they described this condition. What were you thinking?
I mean, I think it was kind of fascinating because it's rare that I think about my condition in such a medical and like objective way, where a lot of the time when I'm speaking about my condition or when I'm asked about it, it's like, oh yeah, I have a jaw thing and I've had surgeries and whatever. But I think it's really interesting to kind of be reminded that it's such a fascinating medical field. And I think it's interesting to see like pictures of like things like surgeries that have been done and things, and think of myself and think of the fact that a story like mine will be in textbooks and taught in universities. I don't know, I think it's all fascinating. It feels very special.
Well, I'll say one thing, you are incredibly special. And one other thing I was thinking about, because you and I have had a conversation about this, is at one point, one of your surgeons had mentioned to you that we could do this fat grafting thing, that we could put fat on one side of your face, right, to make it more even. But he said, you have to get yourself fatter so that we can take the fat.
Yeah.
But what I thought was interesting, and I'd love for you to share, is that, what did you decide about that? And, and he asked you about it. And what did you decide? And why did you decide that?
I said no. At the time, and I still think this, I don't know, the idea of altering my face for any kind of aesthetic purpose didn't feel like, I don't know, it was, justified. Like, I felt like my face was good enough as it was. And I had spent so long, getting used to my face as it was, that I figured, why have more change when I can stick with this face, So
I love that. And Michelle, from being a parent, because I think one of the things that parents struggle with, in my experience, working with families for over 30 years, it's the idea of wanting to do everything we possibly can for them for as long as we have them. And I wonder, when the surgeon brought up this thing about the fat grafting, what were you thinking?
I was thinking how impressed I was with Jazara being so sure about what felt right for her. He asked her, and he tried to make it light by saying she could eat a lot of donuts and stuff. And she was, she didn't want to do that, which I was happy to see that she felt comfortable as she was and didn't opt for that. It's almost like, a child would say, yay, I can eat a lot of donuts. And, Jazara was not at all swayed by that.
Well, donuts are hard to resist, but I think that, and I just think it's such an important point for any providers out there that are listening to this, that that you really need to include the patient at a very early age. And Dr. Bergfeld did mention that very early on. So I think that was a message, that has come through from all of you. And then I wanted to ask you, Michelle, and I knew you when we offered you a very, very complicated surgery and Dr. Bergfeld talked about that. There's a lot of controversy about the surgery called mandibular distraction. And she had that when she was only about 4 months old. So I wonder, and you said yes to it, and you went through the process, which did involve 2 surgeries. We had to put the devices in, keep them in for 3 months, and then take them out, and you had to care for them. And I wonder, what would you have to, what suggestions or what thoughts would you have for parents who might be listening to this now, who are now being offered this procedure at whatever age? What, as you think about it now, what might you want to say to them?
Well, I didn't have a choice, because even when Dr. McCarthy, finished the surgeries and it was at the end of her care with him, he literally said, "I saved your daughter's life." And he did. And I say that because her breathing and her ability to take in enough food or formula was hindered so greatly that she was failure to thrive. I mean, she was an emaciated baby at one point. And
And I also think I remember, I'm sorry.
Difficulty. Nope. You
No,
could see
go
her
ahead.
chest, like that she was struggling to breathe. You could see it.
Right. And I think I remember that the only other choice for you, there was a choice, and that the only choice was to have a tracheostomy. And Dr. Bergfeld mentioned that as an option, and it is something that, is also a life-saving measure. And so, so I understand when he says he saved her life. I know it sounds like, he came in, like Superman, but I think what he meant was that you really needed she really needed a very drastic surgery. So again,
Yeah.
I wonder, what about other parents who might be listening to this right now? How do you, what would you say to them because it's a daunting question that gets placed, in front
Yeah.
of you.
I mean, so her first surgery was the removal of a cyst in the back of her throat. And it was at Montefiore Hospital, which is known to be like one of the best children's hospitals. And that is where the doctor said he wanted to do a tracheotomy. And as I told you before, we just happened to be in New York City. And I can't remember who, but somebody suggested that we get a second opinion and that we meet with Dr. McCarthy. And had that not happened, she would have had a tracheotomy. So I always think of it as such a blessing that we were in New York, that there was another option, and it was it created, like, I mean, we feel like family, like we have been through this, as you know, since she was an infant, and the bonds that are built and the decisions that have to be made as you go through. It's so important to have a team and a doctor that you really trust.
Yeah, and that's what Dr. Heike was actually saying, at the very end, and a couple of times, that the importance of, a coordinated team, because you mentioned there were feeding problems, breathing problems, some of the kids have hearing problems. It's not just about the surgery. And I know you learned that, over the years with her. Surgeries are, certainly very, very important. But, again, and I think, for the providers that are out there listening, a surgery like a distraction or jaw surgery, I think it's just really important to prepare the families in a very realistic way, because I think with jaw distraction, as you knew, we had to tell you they go in and stay in for 3 months, you know?
Yes.
You've got to plan your life around it. So, yeah, I think that, I know it was a tough decision for you. But I would definitely recommend, for all families that they look to a coordinated team approach. And as Harry mentioned, the American Cleft Palate Craniofacial Association has those listed. So, I wanted to put a plug in for that. Jazara and Michelle, I wanted to ask you, we have a few more minutes and then we'll have more questions for you at later. But I wondered what it was like. We're talking about the school age and Dr. Heike was talking about some of the psychosocial issues. I think one of the biggest, from what I've heard from parents, one of the biggest problems is sending your child off to school. And how was that for you? And for Jazara, did you go through, and I think a lot of parents worry, about sending their kids to school and how are they going to be treated. So wondered what your thoughts were about that and any advice you have for parents and for kids.
I mean, I think that I have had a very lucky experience growing up because my parents were able to be very conscious and very dedicated to putting their child in atmospheres that were filled with love and acceptance, which I think can be rare. For example, my elementary school, we'd have banners of supporting peace and kindness and love and acceptance. And, I think that a big reason why I had such a good experience growing up with a craniofacial condition, and why there was never much struggle with, my social surroundings was because I was always surrounded by love and acceptance for who I was, no matter what. And I think it can be difficult, but it's really important when you find those people and those communities that will foster love and acceptance no matter what.
Absolutely. Michelle, any last thoughts on that? And one thought, what about when you're not sure that school, I mean, not every family has the option of choosing that's just perfect like that, where there could be some struggles. What is your advice when they, in terms of dealing with that?
I mean, we literally just got lucky. I didn't know that this school around the corner was going to be the kind of school it was at the time. I was terrified about how she might be received by the other kids. And
I think a big part of it was that also I was taught to love myself first. So regardless of where I was put or how lucky we got, I was also made I understood what it meant to love myself and to have that self-esteem so that if I ran into situations that weren't as great or accepting, I was able to pick myself back up.
Awesome. Awesome. Well, I think we're going to probably talk more about this in our Q&A that's coming up. We're going to bring everybody back into the conversation. We have so many questions. We need another hour just for these questions and answers. So, but I think what I want to try to do is pick one that's for everybody. So get ready because you're all getting a question. I have so many. So the first question was from I believe it was from someone who I actually might know, but it's from Elizabeth, and we had a question about facial reanimation surgery, and so she wanted to ask you a little bit more about that, and is that possible to do as an adult, which I thought was a great question.
That is a great question. Yeah. So yes. First, I'll answer the second part first. Yes, it completely can be done as an adult, and in fact, it's probably done more frequently in adults who have had strokes or for whatever reason aren't able to move their face. But it certainly can be done as an adult. The surgery the way I think about the surgery is in thirds. I think of the upper third of the face, the middle third of the face, and the lower third of the face. And the upper third is really about your eyes and whether your eyes close completely when you sleep at night or not. And because some people, if they can't move their face or part of their face, their eyes stay open, their eyes get dried out, they have to use eye drops. So there are some surgeries that we do to help patients get their eyes closed when they sleep at night. For the lower third of their face, it's really how the lower lip moves. And in that case, we'll actually stop the other side from moving by using Botox or by removing some of the muscle on the other side so that the lip doesn't pull down so much and make an asymmetric smile. And then the middle third of the face, that's the part where your smile is. And so that's where I think about the what some people call a smile surgery, where a nerve is taken from your leg or somewhere in your body, and a muscle is taken from, we use the leg usually, and that's moved up to the face so that the corner of the mouth can move into a smile. There are different aspects of these procedures that different teams do, or different ways that they do it, but these are the procedures that we offer at our team, and certainly can be done as an adult too.
All right, great. So I have a question for Carrie, and I think you touched on it a little bit actually too. Can craniofacial microsomia be diagnosed prenatally? And if so, how do you do? Is it an ultrasound, a blood test, amniocentesis? And then in addition, is if I do have that condition, how likely am I to pass it on to one of my children?
Yeah, that's a great question. I will say from a practical clinical experience, in fact, we were just talking about this. We have a prenatal clinic for children who are identified as having facial differences. I have not ever had a prenatal consultation with someone who had a prenatal diagnosis by an OB or through ultrasound. I would say that when we meet kids in clinic during that newborn period, we do have families every once in a while, and I think Michelle spoke to this earlier, that they maybe in 2020 hindsight on the ultrasound identified something that could have given an indication, but often that's not specific enough to facilitate a prenatal diagnosis. And I don't have a great explanation for that because I know our prenatal imaging is getting better and better, but I have not yet met someone with a prenatal diagnosis, nor have I had any colleagues who've had the opportunity to meet with a family prenatally.
I thought what was interesting, Carrie, and we had this conversation before we started, is that Michelle was saying that, and I've not heard this before, maybe Craig, you have, is that Michelle thought that on the sonogram of Jazara, she saw the skin tags. And I said,
Definitely.
Whoa. And that wasn't pointed out by the sonographers. And I said, I want to take a look at that. I want to see that sonogram because that is super unusual, right? I mean, just something I'm not used to. So
yeah. I haven't heard of that either. That's remarkable.
Right. As I was saying before, the one thing I have seen is, certainly if a baby with craniofacial microsomia has a cleft lip, the cleft lip could be picked up on an ultrasound. But I just, it's just the other thing that I remember seeing is when a child has Pierre-Robin sequence where they have a small lower jaw and you catch them on that side view on a 3D, sonogram, you can sometimes see that. But for craniofacial microsomia, even though it's so common, in terms of craniofacial conditions after a cleft, just haven't seen it. So I just thought that was really interesting that you said that. And I want to see that sonogram.
Yeah. And you could, she was sleeping with her mouth wide open and her lower jaw, you could tell it was smaller in hindsight, of course.
Yeah. So interesting. So I have so many questions. I don't even know where to go next. But let me just let me throw something out that let me ask Dina about it. But we can all jump in. It's any suggestions or referrals for caring for adults who have corrective surgeries as children and are now dealing with new issues related to these procedures. And also, and I'll throw this to Dina, that the majority of resources on our MyFace site, and I think on many sites, are for pediatric patients. And where do we see the resources for adults?
Well, I can answer that second piece, which is for
Yeah,
the
why don't you do that, and then we can jump back to Carrie and Craig.
yeah. So it is a very good question, and I hear it a lot. You know, when kids reach the adult years, and what they don't, there are not as many resources for them. So at MyFace, for example, we have an adult group that is peer led, and we have done an adult retreat, really focusing on those needs, because those needs are very different from a child and what they need. And also, it's harder to, what I've heard over and over again is, I never knew someone when I was younger who had a craniofacial difference like I did. And to find that community of people, and know that they're not alone, that the things that they think about, others think about too, is huge. So it is something that I am very passionate about, is how do we help the adult community also.
Yeah, I think it's something that a lot of the groups are looking at, definitely at the ACPA. We've been talking a lot about that. And one of the things we've done is try to bring more adult voices, adult patients with craniofacial conditions, to our annual meetings so that we can hear and learn from them and see what else we need to do. So thanks for that answer. And then Carrie and Craig, I think there is that big challenge of going from pediatric to adult care, and I wonder if you had any quick thoughts about that.
I'll speak from the surgeon side of things. You know, I think, I mean, it's a challenge. It's really hard to find adult care. And that's part of why we try to get everything taken care of that we can before they leave our team. I know personally a lot of craniofacial surgeons who have a little bit of an adult practice. So I personally have an adult practice which focuses on craniofacial trauma, but I also see adults who were born with different craniofacial conditions. And it's frustrating because, you know, I have a patient who was born with a cleft and they have VPI, but I can't get a speech pathologist to see them, and I can't get someone else to scope them. And so you lose the team aspect of care, but you can often find your surgeon if they have at least a little bit of an adult practice.
You know, I wanted to use this, if I could, for a plug for one of our 13 now webinars. There is a webinar that talks about how to prepare your patient, actually, and yourself or your child to transition from pediatric to adult care. And it's something that has to start really early. You know, you don't wait until they're 18. You start thinking about it, you look into it. And we're one, you know, when I was at NYU, we had, you know, we were lucky because we were a pediatric unit within a medical center. And so our patients never had to leave. You know, so for example, for Jazara, she doesn't have to worry because she can have the same surgeons in the same medical center forever. But for those who don't have that option, I think it's something that, you know, we need to prepare our patients for it earlier on. So thank you for that question, because it was sort of multifaceted. I have a couple more questions on me. I know that there was one that is from a speech language pathologist, and thank you for that question. And she is a school-based speech language pathologist. How can I best support individuals with the conditions covered in this webinar? Karen, let me throw that question to you. And also to Michelle, as who is a social worker herself. But let me ask you, Carrie.
First, I have to say it's awesome that there is a school-based SLP who is asking that question, so that's great. I would say that I work obviously closely with our SLPs who are in communication regularly with school SLPs to help address the specific needs for an individual. So I think it's one thing to know generally the things to consider, but like anything else, we're talking about individual treatment or therapies for a child. And so you really want to make sure that you're communicating with their subspecialists. about any specific needs they have. So that's what I would say is it's awesome that you're here and getting some general information, but if they have a local team and a local speech and language pathologist connecting directly with them to make sure that the things that they're working on in school are in coordination and well informed by their clinical diagnosis.
Michelle, any thoughts? Because one of the things I was thinking is, sometimes there are SLPs that see kids in the school who have craniofacial microsomia, but they're not treating them, or they weren't referred to them. How do you approach that? It's one of those things where sometimes I think, people feel uncomfortable going up or asking the parent, but I wonder, but there have been some patients that we have received because a teacher stepped up and noticed an issue. What are your thoughts? I wonder what you thought about that.
I mean, the speech and language was coordinated by the preschool. By the preschool, and then they collaborated with the school, and so Jazara went right into speech and language as soon as she got to kindergarten, and she had it even before kindergarten.
Right.
And I think the social emotional piece, how they see themselves and how they see themselves reflected in the eyes of their peers, like how they're received, how they're, what things are like for them socially, I think is really important.
Right, for them to be on the lookout for that. Yeah, so it looks like I'm being told that we have room for one more question, and oh my goodness, to everyone, I have so many questions, I don't even know where to start. So, but I do have one question that just popped up that I think is interesting from Lizzie. And Lizzie asked, if someone has a subtle craniofacial microsomia but have not been linked with a craniofacial team, are there certain symptoms we should look for to escalate care through their pediatrician? That's a really interesting question. I've seen some people on the bus that I think have a mild craniofacial microsomia, and I look and I think, did you know that? Because sometimes it is really subtle. So Carrie and Craig, what do you think about that?
Yeah, it's a great question. I guess I always go back to kind of what are the goals, right? So we want to make sure kids are healthy, happy adults, well-rounded. And so in terms of pediatric care, thinking about all of the things that are needed for that, right? Oral health, occlusion, feeding, eating, obstructive sleep symptoms. Sometimes even subtle jaw asymmetry can, in combination with large tonsils and other things, create problem sleeping.
Right.
And there are a lot of parents that don't appreciate that snoring isn't common or shouldn't be considered normal in teenagers. And so, again, if there are any symptoms, sorry, Jazara.
Oh, Jazara, do you snore? Sorry.
Oh my God, my friends, they love me for it.
Yes. So those are the kinds of things that we think about in terms of kind of care recommendations. I think also hearing, I've had older teens that had not, they don't have outside ear differences, and so they didn't have a hearing test. And I think that's a really important part of care to make sure that we've really evaluated hearing. So I would just bring the question up with your pediatrician and think about those kinds of questions.
Terrific. So I wanted to we are going to have to wrap this up, which is really upsetting to me because I can't even tell you how many more questions there are. But one of the things I was thinking is that we're going to take some of those questions and try to figure out how we can, answer them in another way, in another forum. And so stay tuned for that. So that does conclude. Oh, and just one quick plug. This is Honeymoon. And Honeymoon has actually is a puppy with a cleft. And so, and Michelle and Jazara recently adopted Honeymoon. So just wanted to bring her in for the webinar as well. Not our patient. We're leaving her alone. So I wanted to just thank Dr. Heike, Dr. Bergfeld, Jazara, Michelle. You guys have been incredible. Learned so much from you. I think we always learn from each other. And I'm going to now turn it over to Dina to wrap things up for us.
Thank you all. And I just want to thank Pat and thank our speakers for an incredible presentation today. And I hope everyone enjoyed the program. I do apologize, as Pat said, we didn't get to all the questions, but if you have additional questions, you can send them to info@myface.org. At MyFace, we strive to provide the most helpful and informative resources. To help us do so, we ask that you take a few moments now to complete a brief survey by using the QR code provided or by visiting www.aoic.net/myfaceoct232024 eval, and letting us know your thoughts. We will also provide this information in the follow-up email you will receive after this program. MyFace provides important direct services that offer guidance, resources, and a supportive environment for all who participate. For more information about the programs and services we offer, please visit us at myface.org. Join us for our monthly podcast series, My Face, My Story, featuring interviews and roundtable discussions from the craniofacial community. This series aims to help educate the public about craniofacial differences and what those with facial differences deal with as individuals and as a community. Visit myface.org/mystory to register. I also want to share that this Sunday, from 4 to 5 p.m. Eastern Time, we will be hosting a virtual chat called Spectacular Stories and talking about what Halloween means for those of us in the craniofacial community and how those outside the community can better help your child in celebrating Halloween and being sensitive to those in the community. So I hope you'll join us for that, and we will be sharing more information in the next day. I also want to say that MyFace offers a series of free virtual support groups for members of the craniofacial community. There are 6 support groups in total. There are parent groups in English and Spanish. There's also a support group for expectant parents and parents of infants. There are also support groups for individuals with facial differences, including an adult support group, an adolescent support group, and a drama therapy group for youth aged 10 to 4. Coming in January 2025, we will have our next installment in our Transforming Lives webinar series on the topic of diagnosis and management of the individual with cleft lip and palate, featuring Dr. Roberto Flores and speech-language pathologist Meg Lico from NYU Langone Health in New York. Further information will be available on the MyFace website soon. Again, thank you for sharing your time with us today. Have a wonderful evening.